Hi all, welcome back to Nursing Lectures. So today we are dealing with new topic of OBG fourth year, that is cephalopelvic disproportion. It is also come under for 5 mark questions and 3 mark questions or answer briefly. So let's begin the cephalopelvic disproportion. Before moving to that, if you found this video is useful for you, please like, share and subscribe. What is cephalopelvic disproportion? We can simply define from the name itself, the term itself. Cephalo means related to head, and pelvic means related to pelvis, and disproportion that means there is something related to proportion of the head and pelvis. So simply we can say cephalopelvic disproportion is the baby's head or body is too large to that can be passes through the maternal pelvis, but maybe it may be the body or head of the fetus may be very big, so it cannot be easily come out to the maternal pelvis. This is also called cephalopelvic disproportion. The disparity in the relation between the head and pelvis of mother is called CPD. Next one is the cause. The cause can be classified into two: maternal and fetal causes. What do you mean by maternal causes? Due to the abnormalities of the maternal pelvis, that is, small contracted pelvis, and any other pelvic deformities. Then moving to the fetal causes like macrosomia, means the baby weight is more than 4 kilogram. Then hydrocephalus, means baby's head is too large, and malpresentation such as breech presentations. These are the causes of cephalopelvic disproportion. Moving to the types of pelvis. The types of pelvis, usually women have gynecoid pelvis. It's help for our labor. Then next one is android pelvis, that is heart-shaped pelvis. Next one, anthropoid pelvis, that is long pelvis. Then fourth one is platypaloid pelvis, that is flat-shaped pelvis. Usually the android and platypaloid pelvis causes CPD. Clinical features. What are the clinical features of cephalopelvic disproportion? First one is prolonged labor. In primigravida, usually the labor duration is 12 to 14 or 12 to 16. And in multigravida, it is from 6 to 12. So, in prolonged labor, the duration may longer. It is more than 16 hours, or in prime it is usually more than 14 hours. But the entire duration is longer. So this is called prolonged labor. The next one is molding and capped formation. It is seen on the head of the baby. Then next one is high presenting part, such as breech or bra presentation. Next one is fetal distress due to the tight fixation of the head. The baby does not receive enough oxygen, that leads to fetal distress and failure to engage. Then moving to the diagnosis. What are the diagnoses of cephalic pelvic disproportion? Cephalic pelvic assessment. We can assess during the pelvic examination. It is also usually determined by palpation, by touching directly to the pelvis and using X-ray. The smallest pelvic diameter is determined by the X-ray pelvimetry, while the biparietal diameter of fetal head is determined by sonography. These are the diagnostic procedures. Then next one is abdomen and vaginal examination and USG, and we can also done trial of labor, induction of labor. The induction of labor is an important topic in OBG. We will discuss in later. Moving to the management, in the diagnosis I said that trial of labor or induction of labor can be done as in the management. So we can save the baby from fetal distress or fetal death to allow vaginal delivery. In the uncomplicated cases with the minor contraction, vaginal delivery is allowed under the supervision of experts. Delivery is accomplished by the forceps or Wendo's instrumental delivery with deep episiotomy. For what we are performing deep episiotomy? To prevent perineal injuries. Then we identified using USG or priorly, we identified that the patient may have CPD. We can conduct elective Cesarean section. that is contraction of both the transverse and anterior posterior diameter of mid pelvic plane, we can conduct what? Elective CS. Then emergency cesarean delivery. If you found during the last stage of labor, the patient may have CPD, we can perform emergency cesarean delivery. There is no dilation of the cervix or descent of the fetal head after a period of 2 hours in the active phase or arrest of labor. We can perform emergency cesarean delivery. As a nurse, we have important role in the CPD management. What are the nursing management? We can perform or monitor fetal heart rate during the labor, and we can record the labor progress in the labor sheet. Then we can provide emotional support to the patient, educate the patient what is going on, what are the procedures we are done. Then prepare the patient for CS. If we found that on USC that a patient may require CS Cesarean section, so educate the patient about what are you done in the CS, what are the preparation, etc. Then perform aseptic technique during the procedure. Then moving to the complication, if we not treated the CPD improperly, it may lead to severe complication such as obstructed labor, uterine rupture, rupturing of the uterus, and fetal distress due to poor oxygen supply. The fetus may be or the baby may be lead to death. Then PPH, postpartum hemorrhage. The PPH also was one of the important topic in OBG, most asked for long essay and answer briefly, short note. That is one of the complication of cephalopelvic disproportion. So this is about the cephalopelvic disproportion. Usually it is asked for not coming asked for essay questions. It also asks for answer briefly, short note, etc. So if you found this video is useful, like, share and subscribe, and comment down what is the next topic you want to learn.